Welcome to the Vinci Trebuchet presentation, TEFCA and CMS-aligned networks, an overview for CMS-0057 compliance. This content was presented by Scott Rossignol, Solution Architect with eHealth Exchange, during the August 28th biweekly Vinci Trebuchet public meeting. This presentation and all Vinci presentations are offered under the HL7 antitrust policy to ensure appropriate collaboration and information sharing.
All right, so with that, I'll jump right in. So we're going to answer a few questions on this call. What is TEFCA? I want to make sure that folks are aware of TEFCA because it really helps us frame what the CMS-aligned networks are. I want to talk about how TEFCA can become the future of payer-provider interop and what paths we're taking to get there. We'll then dig into the CMS-aligned network concept, discuss how this really applies to CMS-57F and next steps, and talk really about actionable next steps. All right, before we dig into the content, I wanted to cover a few key definitions. These aren't industry definitions, but I use these terms in this way during the presentation, so I wanted folks to make sure they had a basis to go from. When I talk about a use case, I'm really talking about a defined data flow within a network. And these defined data flows could be from a standards organization like Vinci. Like you could consider CRD as a defined data flow and as a use case. And so that's what I mean. I'm trying to generalize a little bit around what a use case can be, because TEFCA has these concepts called SOPs. Those are use cases. Those are things that tell us what data should flow, how parties should interact with each other in order to interact on a network for a given purpose of use. And I think the HIPAA purpose of use is another big piece of this. A data flow is typically assigned a specific HIPAA purpose of use in order to understand when that data flow can be used and by what parties. Is this a data flow that a covered entity can use? Is it one that a provider specifically can only use, et cetera? I also talk about networks a lot, and the word network is pretty overloaded in terms of how we might talk about it. A network is an organization that connects other organizations or participants, allowing for the sharing of data via these specific use cases. So we're keeping that pretty high level. The eHealth Exchange is a network. TEFCA is a network. There are a lot of private networks like Availity. So there's a ton of different networks out there, and any of them could kind of leverage these same concepts. Even an application that allows connectivity between its participants could be considered a network. All right, so high level, what is TEFCA? TEFCA is the Trusted Exchange Framework and Common Agreement. The goal of TEFCA is to enable connectivity and data sharing among participants of TEFCA. So it's really enabling specific use cases so that participants are able to trade data based on those use cases. There are participants of all types, so providers, payers, patients, public health, and federal and state organizations are really the key participants in TEFCA. And then there's a lot of software vendors also that provide capabilities to those key participants, or even could participate on their own in some circumstances. All right, so digging into networks a little bit further, networks differ between what a point-to-point interaction can be. Point-to-point interactions are really about two organizations that are doing something with each other. They're trading data with each other. They have sort of their own defined use case. Point-to-point interactions are perfect if you only need to trade data between two parties. But as soon as you need to trade data between many parties, or you need automatic or required responses across a network, a point-to-point interaction does not work. It does not scale. It's too expensive for those parties to implement and maintain. So networks are typically, one connection, and there are many responders that can then respond from that single connection that you make into the network. Networks can be formed in different ways. You can have sort of a mesh where everyone communicates directly with everyone, or sort of a hub and spoke model where there's all the communication goes through the center. So it's important to understand these concepts differ and what value they add when we're talking about connectivity for healthcare data. All right, so TEFCA works in at a high level in a couple of ways. First, the common agreement. The common agreement establishes the legal protections that are necessary in order to trade data. So if 10 organizations join a network and they say, hey, we're going to trade data with each other, and we're all going to agree to these same terms, those 10 organizations just sign one contract. They don't sign 9 other contracts with each other organization. And that's what that common agreement is. It's the contract that allows organizations to trade data. So that's crucially important. It's a huge part of why we say that a network provides a faster, more scalable approach to connectivity, because you simply do not need to bring contracts with each individual participant you're trading with to the network. You can leverage the contract from the network, and that's all you need. There's a concept called the QHIN Technical Framework, or the QTF. This describes the functional and technical requirements for QHINs. QHINs are the main vehicle within TEFCA that you trade data through. They're the actual networks that enable data trading. So QHINs enable connectivity between participants, and they follow the QTF in order to establish the technical guidelines to do so. Finally, you have the Trusted Exchange Framework, the TEF part of TEFCA, which sets the traffic patterns for data sharing and establishes response requirements. So this really is like your use case, but it also does this really important thing, which is require responses for certain use cases. I'm going to touch on this more, but a network of optional responders is a network where nobody responds, right? If you have a network where no one is required to respond to any of your queries, then how do you get to a point where you actually get responses from those queries? The core concept that makes most networks function is the required response for a given use case. In the case of TEFCA and prior networks like Care Quality, the eHealth Exchange today, the only required responses are treatment. And that's why we don't have the ability as a payer to go get data for healthcare operations or payment use cases. We're moving in that direction, and I'm going to talk more about that. But that response requirement is such an important part of a network, and moving towards required responses is really the main goal of what a lot of the activities that happen today. Okay, I already touched on the required responses piece. That's one of the core benefits of being a TEFCA participant or joining the eHealth Exchange or any other organization. Those required responses for certain use cases allow you to obtain data in a reliable way across participants so that you can behave in a standard single manner on that network, and you can obtain data from anybody that has data pertinent to you. What's really important here is that in February of 2026, the healthcare operations use case is slated to become required. That's super important for payers, because if you can rely on that as a source of data, that you can join TEFCA and you can go get CDA documents for the healthcare operations use case from any responder on TEFCA, you now have a very viable path to all the data you need. So that required response is really something I'm watching, and I'd really like to see that does truly become required in February of 2026. That's one of the things I'm going to talk about a little later, is how do we get to requiring that, and beyond just saying, hey, it's required, how do we make sure that the community is really involved and able to say yes to allowing access to that data? Network connectivity, governance, and the standardized exchange patterns are really important parts of the network as well. Of course, we've talked about connectivity already, but what the networks also provide is governance. They allow us to take a use case that's nascent or doesn't even exist today and bring it both into fruition to define that use case to a point where it's something that you can say, yes, this is a trading pattern that I can support today, or I need to do wide development in order to support this data trading pattern or data exchange pattern. That governance process allows the creation of those standards that allows you to then fully define what work you need to do and how you might participate. And those data exchange patterns are really important too. For the healthcare operations use case, if one responder said, hey, you need to have these specific headers in this specific body, and you authorize in this way, and then another responder did things differently, and then another did it differently, you don't have anything that's scalable. You have to go and do development for every responder on the network. And so governing the way that responders conform to requirements, ensuring that there's strict conformance and that it's scalable across responders is really a huge part of the network and what the governance process does. All right, TEFCA is not without its concerns. Obviously, there's it's still growing and it's got a ton of momentum, and I think that we're going to see a really amazing network in the future. But there are different things that we need to solve in order to get there, and of course that's true. Otherwise, healthcare interoperability would be easy today, and I don't think you'd be joining this call. So key concerns around this: HIPAA compliance is the first. The providers worry that they're going to expose too much data, that they're going to be legally liable for exposing data on TEFCA, especially for that healthcare operations use case. There are a couple of like key HIPAA mandates that mean providers really need to think about what data they're exposing and how they expose it. Of course, minimum necessary being the like primary one. So HIPAA compliance is a big thing. It does need to be tackled from both like the regulatory perspective, and we're going to talk more about that with the CMS-aligned network concept. I'm going to circle back there because the CMS-aligned networks actually allow us some breathing room around minimum necessary. So I think that's a huge part of this. Yeah, and sorry, just to talk more about that, the CMS-aligned networks, if you take anything away from this, like the concept of that is really intended to address the key concerns that we're seeing with data interoperability and TEFCA today. So we're going to talk more about like how it addresses some of these things, but that's one of the core reasons that they're doing this is to address those concerns and to move the interoperability forward. So like that's a really important concept to consider here is that CMS-aligned networks are not in competition with TEFCA. They are meant to address the concerns that are being raised due to TEFCA, as well as due to current other data exchange patterns that exist outside TEFCA. Okay, fees are another consideration right now. I don't believe that any payers have joined TEFCA. I haven't heard of any. I could be wrong. There might be one or two out there, but payers are largely holding back from joining TEFCA. And one of the main reasons that they say they're holding back is because they can be assessed fees for the TEFCA HCO use case. What that means is that a provider might actually ask for 10 cents for every CDA that the payer requests. You know, something along those lines is possible under TEFCA. And that kind of breaks the exchange pattern because it means that you can't have a common agreement anymore. You have to actually have a negotiated rate for exchange of data under that use case. And so fees are a big issue in the process, not just because of the cost that they incur, but because it breaks the common agreement and requires participant to participant agreements, payer to provider agreements in order for those fees to be defined and that trading pattern to actually be productionized or accessible. Okay, I already mentioned participation is a key issue. How do we build participation in TEFCA is one of the biggest things that we're asking today, and I'm going to spend a number of slides on that in a little bit around what we're doing and how we think that we can build participation and trust in TEFCA. And finally, reciprocity is another piece. Reciprocity means that if you request data, that you have to respond with data that you have. So the idea that reciprocity exists is good. You know, we need to be equal trading partners. If I ask for data from you, you need to be able to ask for data from me. And I think that that's fair, but there are different carve-outs that we need to consider there. It might not make sense if you're only requesting data on the network to have to respond with the data you've requested with or received, for example. So if a patient has an IAS application and that patient just goes and downloads all of their data from their providers and their health plans, should that patient's application also have to make that data available to other requesters? That's a weird thing to do, but it is actually required today. And so reciprocity is another question that we're kind of circling around and trying to answer is like, how do we carve things out in a way that makes sense and still means that actors on the network with data that adds value to the network are required to provide that data into the network or make it available. All right. So there are a number of ways that you can obtain data via TEFCA. I'm calling out three that are kind of most pertinent here. I think the CDA documents are the first way that is currently live. When we talk about TEFCA having 40 million documents flowing through it last month, I believe, those are CDA documents, and those were for the treatment purpose of use, or T-treat, I think is the full name. But that the CDA documents are like, there are billions of these documents going through networks today for the treatment purpose of use. And I think that that's like a really interesting thing, because it's a pattern for data trading that we can rely upon, that we know works, and that we can onboard new use cases into. I'm a big proponent of FHIR, but I think that if CDA documents are working today, that we should pile on and start using those, because they're a good data source and they could solve our problem faster than FHIR because of some different concerns with FHIR, or just the overall need to mature FHIR in certain ways before it can really be productionized and scaled. Facilitated FHIR within TEFCA does become supported starting in June 2026. What that means is that participants in TEFCA can start using it, but they are not mandated to respond, though. I don't think there's a mandatory response date for facilitated FHIR yet. I did want to call out that electronic prior authorization workflows are not defined yet in TEFCA. So, I think that we all want to use a network for electronic prior authorization and see the value of doing so. But today we don't actually have a standard operating procedure within TEFCA. We don't actually have the workflows defined to make that function in that manner, that standardized manner across participants. So there's more work to be done with EPA before it can really be used in TEFCA. Okay, so I want to answer a question here about, like, is TEFCA the future for payer-provider interoperability before I start talking about CMS-aligned networks? Because I think that all of this information is pertinent. It really helps build an overall understanding of interoperability. So the key question, or the way that I answer this question every time I receive it, is the chicken and the egg problem here. So TEFCA can be the future for payer-provider interoperability, but we have this chicken and egg situation right now that we need to resolve and we need to grow out of. We need to kind of find the source and find the pattern to continue forward rather than continuing in a circular pattern. So when we think about, like, what does it mean to onboard into TEFCA, and what's the thought process across parties in TEFCA? There are sort of five different, there's, like I said, there's this circular pattern that occurs, and it takes about 5 different steps here. So the first one is that networks really rely on payer and provider participation to provide business value to participants. A network with no participants is not a network, right? Like, you need to have people participating in the network in order for it to be valuable. They are making their data available, they are requesting data as well. So payers will eventually need to join a network if they want to, but what they need to see is sufficient business value to do so. One of the business values for payers to join a network is data. How can I access data on this network? Is data available on this network to me? So the business value of a network to the payer is driven by the ability to access data on the network, which goes back to that concept of a use case and a required use case, or SOP, in TEFCA. So if there's no ability for me as a payer to join a network and be able to obtain data via standard data trading pattern, and without having a one-off agreement with each organization I want to get data from, then I don't really have a network. I don't have anybody to obtain data from on that network if I don't have a standard required use case. As we talked about before, there are no standard required use cases in production today for the healthcare operations and payment purposes. So networks need to show the viability of a use case before they can make it required. TEFCA went and sort of said, hey, we're going to just require the healthcare operations SOP. We're going to do that in February 2026. And I think that that's the right move, but if no one's done it yet, how have you shown that this is viable, and why will providers agree to doing this if they don't see any data, any outcomes from a pilot that use this process, right? How do providers know that minimum necessary obligations are being met with this use case? So there's different questions that we need to answer through a pilot before we can really make this required and get buy-in or sign off from provider organizations. Who are the key source of data in a network that providers are seeking data from, except, I'm sorry, payers are seeking data through, although payers can also obtain data from other payers. That is a use case that we are pursuing. Okay, so providers now, in order for providers to make a decision to say, yeah, let's make this pilot, let's go forward with a pilot, or yeah, I want to invest in this technology and I want to join this network and make data available. But I also want to see data, I want to see reciprocity. I want to be able to obtain my data. And the provider access API through Vinci, which is required as part of CMS-57, is really that core driver there, right? Like CMS-57 purposefully included reciprocity in it with the provider access API, and then the payer side of prior auth and CDEX, their ability to obtain data, in order to give value to providers outside of just improving prior authorization processes. But providers also want to see, like, regionally, that they have enough payers that they can connect to, because they don't want to do a one-off solution. You're not going to join a network for a single connection. And so we have this issue where providers want to see that regional participation. Payers are waiting to see that there's sufficient business value, and hence our chicken and our egg, right? Everybody is sort of sitting back and waiting to see who will join, instead of and so we don't have this ability to drive participation very quickly if everybody wants to see somebody else join before they join or participate in a pilot or use case. Now, it's not all doom and gloom. This is sort of what I wanted to talk through to show what's going on today. Like, I've seen this happen like a number of times over the past couple of years as we've brought organizations in to do pilot work or had discussions with organizations about piloting. So I really wanted to show this, like, this experience that I've been having, so that organizations understand what's going on here, and hopefully you as an organization can avoid this and think it through and kind of find a different route. And I'm going to show some of those different routes that I think make sense here. So we do have payers signing on to networks. The eHealth Exchange has had a number of payers join up. I believe some other payer organizations have joined different networks or different QHINs as well. But we're not seeing strong coverage. We're not seeing like a single region that has all of its payers connected or 80% of its payers connected. And I don't believe, again, that any of those payers have opted into TEFCA. I mentioned the HCO SOP already. So when that becomes required, we need to see it adopted. We need to see organizations bought in and actually trading data on the network. And we need to see participants in TEFCA in order for them to even buy in. Talked through this already. Sorry, I think I should have been clicking as I was talking through these. But the TEFCA SOP, again, is showing it wasn't piloted. I don't believe that we've seen a pilot with this HCO SOP yet. And what that means is that we're not sure of its viability and that there are a number of questions that need to be answered. Hesitation from providers, basically, as well as hesitation from EHRs, or the way I'm framing it is that I don't know when EHRs are going to support different capabilities. We've heard some EHRs talk about supporting prior authorization. I haven't heard a peep about provider access. How will EHRs make fire queries to get data from payers and store that data off so that the provider can use it? I'm very interested to understand where the EHRs are going, how they will adopt these, when they will adopt those, because that's going to drive provider participation. Providers don't necessarily want to invest in a solution outside of their EHR if their EHR is ultimately going to support that solution. Finally, what all of this leads to is that we haven't really bent the curve. We haven't changed the status quo. We're able to slowly make progress in different areas, but in general, what we want to see is far more rapid adoption of TEFCA, because I think once other folks see rapid adoption, they're going to start piling in, and we're going to start getting a better overall participation and representation of different organizations in TEFCA as they buy into the use case and they say, okay, this is my path forward. This is my future of connectivity. Now let's make sure it really works for my business. Okay. So one way that we can break this cycle is that early adopters are showing the value of improved interoperability, and they're talking about it. A number of the folks on the core team of Trebuchet and that join these calls regularly are really considering, they're considering all the aspects of TEFCA, and they're bringing this to their business teams, and they're getting buy-in on using TEFCA and using these processes to get data. Early adopters are, like payers, are also building into their contracts with providers that these use cases, these implementation guides, are the way that they will trade data in the future. I think quality measures is really the biggest one that I see adoption of this in, where payers are stating we're not going to use flat files anymore for quality measurement starting in this future year, maybe 2027 or 2028. We're going to start using FHIR. We did a presentation, Mike Westover did a presentation on this a couple of weeks ago, and how Providence is moving their payers towards using FHIR and using more standardized methods for data exchange. But these early adopters are really showing, like, if you can move this forward and here are some strategies to do so, then it's going to add value to your business, and it's going to break this cycle. It's going to create the connectivity between provider and payer, and then it's going to drive other use cases into that connectivity and make those simpler. Federal law is obviously a key driver of why we're here. I think that interest in this concept wouldn't exist if CMS-57 wasn't really driving federal interest. So I do want to give credit where it's due. Like these rules are carefully crafted to push the industry in the right directions and to break these cycles of adoption or of lack of adoption. I think pilot work is the other big one. I already just talked about, like, the Providence pilot, and I know there's a number of others ongoing. And so, like, different networks and different participants within those networks are coming together to show the value of their use cases and to really, like, build on those. So that's one of the most important things that Trebuchet is doing, is to not just create the pilots, but to get lessons learned from those pilots to improve upon processes and really, like, bring education to the market. Just like this presentation today, like, the goal here is that we can get people educated on why this use case exists, and allow other organizations to create that business value or that business proposal to their internal leadership and get sign off to move forward. So I think that those early adopters and that work is critically important to breaking this cycle. There are regional pilots as well that I think are really important to talk about. So the One Utah Collaborative, and there's a One Washington Collaborative now. Those are both working regionally between payers and providers to create opportunities for pilot work and moving work into production. Utah one was actually driven by regulation as well. And I think that that's really important. It's really important that we address the regionality of the problem of payer-provider communication, because most of the payers that work with a provider are regional payers. They're working in Utah only or in that surrounding region. And if we approach this as a national problem only, then we end up with a pilot between Washington and South Carolina, right? Like, we don't need those pilots for long. We need to see organizations in the same region getting together and working towards production use cases. So it's really interesting to see these win-win models where you can bring payers and providers in a region to get together and say, okay, we're going to try electronic prior authorization or CDEX or quality measures together. And you're not just piloting, you're not just showing value, you're actually moving into production and standardizing your processes moving forward. Evangelization, really talking about these things is important. I think, we need to make sure that folks in the industry understand the value of use cases, as well as the pitfalls. And that's why we're doing education sessions in Trebuchet and really bringing some education to the market around the work that we do. All right. A lot of you folks probably joined for the CMS alignment, so I appreciate you spending 35 minutes with me talking about the baseline details here. So CMS-aligned networks are not all just networks, right? Like, not every organization that was part of the presentation at the White House is a network per se. It's an organization that provides some capability within this space. So I see that more as CMS alignment rather than an aligned network. But there are also networks, and this slide tries to call out those differences. So looking at the bottom bullet point here, a CMS-aligned network is really intended to serve as the implementer for certain rules that CMS either stated outright or hinted towards as part of their presentation, as part of their different press releases and everything else. So networks act as governance. We already went over that, right? And what we're saying here is a CMS-aligned network is providing specific governance around aspects that the CMS press releases have stated. And I'm going to get to what those actual details are in the press releases as well. But CMS alignment means more than that, right? I think what we heard from the CMS press releases is that alignment is surrounding a few topics. Patient access is the most important topic. It is my favorite topic in these announcements. It is critically important, and I think will drive other interoperability in the future as well. In TEFCA, patient access is called Individual Access Services, or IAS. And what CMS has said is that patients have a right to all of their data, structured and unstructured. That's what CMS-aligned networks are going to provide, and organizations that have signed this pledge should be providing data to patients. That's already mandated. CMS 9115 and previous rules already mandated that patients should have this access. But what we need to do is improve how patients access that information. Is it technically complex? It shouldn't be, right? But it is today. It's very complex and hard to do. And we need to make more data available to them. And I want to comment here that nothing in HIPAA allows an organization to keep data from the patient. The patient has a right to their own data in almost every circumstance. So this is a no-brainer, and it's something that the industry is moving forward with. A couple of key points. The payer access to FHIR or CDA data relevant to a member's encounter for 60 days after a claim submission, as well as for care gap data, this is in the text that CMS stated. So what CMS is saying here is they're setting a bar that providers need to make this data available to payers and in these formats. And I think that that's important because it allows us to see what direction we're heading, right? Are we, what the direction we're heading is not just use FHIR, use these implementation guides. It's saying, like, in this circumstance, you must make this data available. You cannot put up a wall. And I think that that's really helpful because now payers can say, well, all right, I get this. I need this. This is great. And they can move forward with some understanding that somebody else that signed the CMS alignment pledge is going to say yes. Providers, on the other hand, need access to payer claims data via the same networks, right? So reciprocity, again, very important. Finally, there's this concept of encounter alerting. I'm skeptical that we're going to see this hit production quickly because I don't know how. But this encounter alerting is very interesting because one of the key things about data exchange use cases is that most data exchange use cases are pull-based. Organizations decide, I need data, and they ask for data, either from a network or from an individual organization. but you don't know when to pull data, right? So encounter alerting via an ADT interface or FirePub sub in the future gives you a trigger. And having that as a standard concept within a network is a really big value add, because that trigger can be very valuable to finding out when you need to retrieve data. Electronic prior authorization via FHIR was one of those other CMS alignment things. Totally agree with it, and it is part of CMS-57. All right. In the press releases, so we saw a number of press releases, and you can actually see the requirement numbers here. There's one on June 3rd, there was one on July 30th. And so those press releases stated specific information, and that description's right here. You can go back to this slide. We'll make the presentation available later. But what we did is we broke these requirements down, and we sort of like named them and categorized them, right? And so I think that breakdown of requirements is like really nice to understand what is it that CMS is saying, what directions are we heading, and a lot of this presentation around CMS-aligned networks is based on this categorization. So I talked about the key items before. You know, these bullet points are some of the biggest ones. I'm going to talk about a couple others in a moment. So those requirements, as I can break them down for you, you know, patient access and empowerment, I've already harped on this one. I'm not going to spend more time on that. Provider access and delegation is another topic. These are the 4 topics that CMS actually wrote up. So provider access to that claims care quality gap data from payers, payer access to providers in a reasonable time frame using those standards that we talked about, and then the ability to connect to a network to obtain that information, to understand who's on that network, so that participant lists, use standards to get the data, and to be able to look those organizations up in a directory and find patients via a record locator. So these are all very baseline concepts, sort of kind of the underlying requirements that CMS stated, which I then rolled up and we talk about further in the requirements I talked about before, like the IAS requirement. So CMS-aligned networks themselves are the backbone of the data exchange, but they don't provide 100% of the requirements, right? Like just thinking about like providers must make this data available to payers, payers must make this data available to providers. So those organizations are very important as part of this process. But what a CMS-aligned network can do is they can certify that this organization is compliant or not compliant. So again, governance plays a key role here with CMS-aligned networks, where the network can provide governance over those requirements. They can fully state those requirements so that each organization can decide whether or not they want to join that network and not just sign the pledge. And then once those requirements are fully stated, they can be implemented, et cetera. Right? So governance is incredibly important, and that's where the networks are providing that backbone. I think it's important to note that TEFCA QHINs and CMS-aligned networks are not the same thing, but they're not mutually exclusive either. So eHealth Exchange is a CMS-aligned network. It's also a TEFCA QHIN, but not everybody has to be both or either, right? You can choose which ones you want to take. The CMS-aligned network concept is really much more generalized than TEFCA, whereas TEFCA is much more specific. And sometimes they overlap, but in general, these concepts are different and not mutually exclusive. Okay. The CMS talks a lot about these concepts as well as part of their press releases. I struggle to see how they're, you know, truly part of the CMS-aligned network concept, but I think they're important backbone elements that we need to make sure we understand. The National Provider Directory is something that CMS has stated they're going to do, right? They are moving forward with the ability to provide provider data via FHIR at a web URL. A lot of you are probably already familiar with NPES. You can get data from NPES. The data is questionable quality from time to time, but it's still better than nothing. The National Provider Directory should be a FHIR layer of NPES, something that's queryable and easier to interact with as a FHIR application. What I want to see is I want to see TEFCA and other CMS-aligned networks integrating with the National Provider Directory. So if you have an NPI ID, you should be able to understand what URL do I query to get data from that provider that has this NPI ID. So that endpoint to NPI mapping is like really crucial, and it doesn't exist today. So I'm very excited to see this directory in FHIR so that we can push that forward. The IAS use case is really important. I already talked about that a good bit. I want to see that succeed, and CMS wants to see it succeed as well. Identity management within that IAS use case is probably the most important component of it, where a patient actually has IAL2 identity verification, and then they don't have to log into a portal with each individual responder. The responder can just accept that identity and release data. So it really takes a lot of the friction out of the process for a patient to obtain their own data. One thing I'm pretty excited about is audit log transparency. We have not seen audit log transparency in national networks to date. So we don't know whose data is flying over that network, and those individuals do not know when their data is actually exchanged in most cases. I think that should be a mandatory thing, and I think we're moving in that direction where a individual using an IAS application. So I've asserted my identity. You know that I am Scott Rossignol, and now the network should be able to provide audit data to me as an individual to tell me when was my data requested and by whom. Digital insurance cards are another piece of this. I think if you haven't seen the Smart Health IT cards and the different value that can provide as part of a workflow for patients, definitely check those out. Those are gaining steam as well, and I believe HL7 just released a new standard for them, or published a new standard. The last bullet point here is, I think, a big topic for the payer-to-payer space, especially the consent management is very important for patients to be able to actually consent to their data being exchanged, really outside of the treatment use case. But in most cases, what we want to see is we want to see a patient's consent before we release data. The ability to exchange consent via FHIR is a core need in order to make that happen. So we're excited to see more infrastructure, more standards evolve that allow for consent to be exchanged and understood between parties before the data is actually transferred. I think, again, this will help ensure trust in the network and make for more patients, make for a better network where we can respect the privacy of patients who opt out, for example. All right, so talking a little bit about CMS-57F, prior auth connectivity between payers and providers is feasible. It's going to be feasible within TEFCA. TEFCA is going to support the specific data exchange patterns within the CRD, DTR, and PAS guides. Even though the SOPs are not yet published, we're going to see that happening. But for now, what we're saying is, go ahead and do that outside of TEFCA, because we need to get pilots started and working. So connectivity is going to be a very useful subject within the CMS-aligned network concept and outside of TEFCA. All right, so those networks that are offering connectivity can provide prior auth connectivity, and they don't have to follow a TEFCA standard to do that, but they still can also follow those CMS-aligned standards and give you a little bit more trust in the process, for example, or add value by using the National Provider Directory. I think this it resolves some of those key concerns. I failed to mention earlier here, apologies, I think, but the HIPAA compliance piece that I talked about before, providers are encouraged to share data in a CMS-aligned network using US CDI v3 as the floor for minimum necessary. So, like, I think that that's a really impactful statement, right? What we can say is, I will be able to retrieve any data element within US CDI v3 from a provider in order to exchange data for prior auth purposes. That allows us to now move on from, am I sharing the right data? Am I going to be legally responsible if I expose some data that I wasn't supposed to? Because we know what the floor is, and this aligns perfectly with the FHIR APIs that already exist. So providers can simply make available data via their FHIR APIs to payers, and they should meet the floor of connectivity, and they can leave it right there. They can set their scope so that they're only allowing access to those v3 FHIR APIs, and that should make everybody happy. Payers should have all the information that they need, and providers have a minimum scope that they can feel is acceptable. Fees, we can get rid of fees. We don't need fees on a CMS-aligned network, so you can start trading data in the CMS-aligned network without any fees at all. The network itself is going to dictate whether fees are allowed. TEFCA has dictated that they are. Other networks do not have to do the same. I think participation is also a big thing. Networks have more freedom to operate and determine the rules. TEFCA has certain requirements and has done those for good reason. None of this is critical of TEFCA, but what I see as TEFCA as like the mature way to transact data after a use case has really been proven and everybody finds it acceptable. CMS-aligned networks can be a little bit more of the Wild West, where you need to test something out, you need to pilot it, you need to make it work. Let's go ahead and figure that out, and let's see if it scales. So that's a really interesting aspect here, is that you can go participate in the Wild West as well as the deeply regulated space, and you can achieve value from both of those, and get different value from both of those. I've already talked about IAS and provider access. I think it's clear that we can use CMS-aligned networks for IAS, and as well as provider access requirements, and that should really help to smooth the road, make it simpler to obtain data, and allow folks to understand, yes, I can go get that data from this data source. There are a number of things that simplify data exchange and allow for, faster, easier data exchange. The encounter notification and national directory are the key examples. These are tools that are going to help with a better foundation for data exchange on the networks. And then future goals, like I said, the pub sub concept is a future goal, allowing encounter data to be delivered to you via FHIR based on a subscribed patient that a member of your plan, for example. You could get FHIR pushes every time a member of your plan has a new encounter. So that's very cool. Consent management and audit trail are also very interesting and should help move the needle on different aspects of privacy, auditability, et cetera. And I've already talked enough about those. So yeah, this is that sort of Wild West versus highly regulated space, right? We have the CMS-aligned networks allowing us to figure things out, bringing new use cases, establishing patterns, and then bringing those into TEFCA after they've been validated and the industry is really like ready to go. Let's bring this into TEFCA, right? So we can start off in the Wild West and we can move that into a more regulated space. All right, I'm right on time here. In the last few minutes, we're just going to talk about what's next. What should you do based on what I've talked about already? So first of all is that nothing is really changing in terms of the CMS-57 requirements from the payer and provider perspectives, except for some of the guidance that's should have helped us solidify our path forward and move forward with fewer concerns. Business cases should feel stronger now around these things because CMS is saying, yeah, we're bought into these things, we're doing them. It's not just the CMS-57F rule now, it's more investment here. I want to go back to that advice I provided earlier. Payers and providers should be including the standards or IGs, the network they're going to operate on, and how they'll in their contracts. So anything related to integration, anything related to data needs to get specific about how are you going to integrate data, where are you going to integrate, and like allow that to project your path forward. Allow that to make your life simpler in the future because you're going to all be aligned together contractually. This is not my advice. I'm getting this advice from payers who are doing it. I've heard it a number of times in the past couple of months. I actually heard it this weekend at a conference. So I think like it's really important to understand that your contracts can drive clarity and it can move your IT forward. Okay, CCATO network connectivity, I've already kind of talked about plenty of times. It's important. It's going to help you scale. CCATO network that meets you where you are, right? You need to find folks that understand you and want to help you achieve your goals. There are a number of networks out there, and you can find a good one for you based on conversation and just kind of doing your due diligence there. I always, of course, recommend piloting. Start testing your software and piloting it when it's available. This Trebuchet group is free and open to anyone. We centrally architect pilots to allow you to focus just on the implementation and the work that you have to perform to make that pilot function, to get it off the ground. So you don't have to bring a lot of project management. You don't have to find a trading partner. We're doing all of that for you. All you have to do is bring your technology and be available to do the testing, to fix the problems that we expose, etc. And then keep an eye out for more, right? Like this announcement on July 30th was the first announcement that we're going to see. This administration loves announcements, and we're going to see more. So things are going to change. Keep an eye out. We'll try and keep you up to speed as things do change. A couple of other things. I think that the CDA use case is the most powerful use case for initial data exchange. I would love, like I said, to see the HCO use case go live. I'd love to see payers and providers exchanging CDAs in February. Let's make it happen, folks. I think there are a lot of you that are bought into that. I think if we can get a few payers to the table in TEFCA, we can actually see that required exchange happening, and we can build from there. So everybody, I want you to help me out here and start thinking about how you can do CDA-based exchange on TEFCA, because the use case is required in February and providers are going to be there. They've already signed on, so we need payers to join. My last thing is around EHR vendors. I would love to see more clarity from EHR vendors. I talked about this already. I want to see EHR vendors committing to the CDA use case. I want to see them clearly communicating release dates for key interoperability requirements. I want them supporting the provider access API in a way that we understand and talking about how they're going to do it. Quality measures interoperability is really important as well, but it's not required in CMS-57F. Let's see it happen. I think Michael Westover already showed us that it needs to happen because it's so valuable, and that it can happen if you put your mind to it. Now we should make it easier from there. And yeah, let's make it all work in the ways that it already works, right? I don't want to see basic functionalities like CDA documents gated behind new licensing by EHRs. I don't think that's appropriate, and I think we should be pushing back. All right. We are doing TEFCA and non-TEFCA pilots in Trebuchet. You can pilot a non-TEFCA use case or a TEFCA SOP. We have flexibility in how you could pilot TEFCA, where you can do a one-to-one pilot, sort of a bring your own agreement instead of signing the TEFCA agreement. We have use cases ready. We're very excited to see people participating and moving that forward. So please, if you have the opportunity to pilot something, reach out. I'm at time. Thank you all for joining. And if you have any feedback, please do feel free to email me, or bring something to the group. Thank you all.
Scott, if you have a minute, there is one question in the chat. What about PSV for HEDIS?
Yeah, good question, Linda. The primary source verification for HEDIS is an ongoing topic that the NCQA is looking at. A number of other organizations are looking at how that verification might be done or might be simplified. Right now, it is not simplified. The FHIR APIs would have to undergo primary source verification in order to be used for HEDIS measurement.
That seems like the biggest deterrent then, right? For payers to really use this, they're going to have to crack open PSV audits on potentially grandfathered places where they're already getting data. It feels like it's like in the private sector, there's going to be an ongoing struggle for data sources that have already passed PSV until the governing agencies, NCQA and CMS, are aligned on the requirements around TEFCA because there's no incentive to reopen that can of worms. PSV opens everyone up to incredible risk of not being able to use those data sources.
I agree. I think this is a primary issue, and we're seeing movement in the right directions. Although, yeah, Rhonda has a point here that the NCQA is doing some FHIR data validation. So, like, I agree that we don't have a solution yet, and it is a big problem. But we're moving in the right directions there, and I think it can be solved.
Agree.
Thank you, Scott. Thanks, everyone, for joining. Don't miss the next meeting on September 11th.